So now let's talk a little bit about pleural effusion, a very common abnormality that's found within the chest. Pleural effusion is accumulation of fluid within the pleural space. Pleural fluid is physiologically produced at the capillary bed of the parietal pleura, but it's usually absorbed by the parietal pleura, lymphatics, and the visceral pleura. There are different causes of pleural effusion, including increased rate of formation, decreased rate of absorption, and direct extension from the peritoneum through the diaphragm. So let's just take a look at the anatomy one more time. So we have here the lung, which is surrounded by the visceral pleura, which is right here, the inside layer. The outside layer is called the parietal pleura, and in between the two is the pleural space, where the fluid accumulates. So pleural effusions are characterized by their protein content. They can be transudative, in which they have a very low protein content, and this is usually the result of an increase in hydrostatic pressure or a decrease in osmotic pressure. And causes include congestive heart failure, cirrhosis, nephrotic syndrome, or any cause of hypoalbuminemia. They can also be exudative or have a high protein content, and these are usually the result of an inflammatory or an infectious process, like pneumonia. They could be caused by any kind of cancer within the lung. Hemothorax is considered a high protein content effusion. Empyema, which is a collection of infected fluid, or possibly a pulmonary embolism that results in tissue, can result in a pleural effusion that has a high protein content. Pleural effusions are also characterized by whether they're bilateral or unilateral. The most common bilateral effusions are caused by CHF, and a little bit less commonly lupus. Unilateral pleural effusions are often caused by malignancy, infection, trauma, pulmonary embolism, or cirrhosis. And again, these are somewhat general categorizations, so each of these can also cause the opposite type of effusion. So what is a subpulmonic pleural effusion? Within the pleural space that's just above the diaphragm, there could be an accumulation of fluid, which is really best seen on an upright film. So you can see here that there's elevation of the right hemidiaphragm, much significantly higher than the left hemidiaphragm. And this is really the only finding of a subpulmonic effusion. So if you see asymmetric elevation of the hemidiaphragm, one of the things to consider is a subpulmonic pleural effusion. Often pleural effusions start in the subpulmonic location because of gravity, and then they arise and move up to the sides. So there are two different categories of pleural effusion in terms of location. One is a free-flowing effusion, and this is a normal gravity-dependent flow within the pleural space. These are usually the most common, and the fluid redistributes based on patient positioning. So on the left, we see an image of a patient that's supine. You can see that the fluid layers throughout the right lung. The entire right lung appears somewhat hazy, with the apex being a little bit less hazy because more of the fluid is located inferiorly. On the right, you have a semi-upright film, which is obtained a few minutes later in the same patient, and you can see that the fluid has now dropped down inferiorly because the patient has gone into a semi-upright position. And so now the fluid, because of gravity, is a little bit more inferiorly located. Pleural effusions can also be loculated or walled off, and this is usually a cause of adhesions, in which you have no change in shape or location with changes in patient position. So it's a small collection of fluid that really can't move around at all. And you can see the patient has bilateral loculated pleural effusions. Even though the patient is upright in this position, you can see that the fluid remains in the upper part of the lung on both sides.